Hello, everyone. Hello, and welcome. Thanks for being a little bit patient. We had a little technical issue on the back end, but we are here. That's all that matters. We're good to go. It is a beautiful Wednesday, so thank you, everybody, for joining us from wherever you're at. What I always like people to start out with is let us know where you're joining us from. Are you located overseas, Europe? Are you in Australia? Are you here in the United States, Canada? We love to hear where everybody's from. It always makes us happy to serve the international community. So welcome for joining us. Today is an Ask the Experts. Ask the Experts is an opportunity for us to answer some of those pre-submitted questions as well as your questions live. It gives you a chance to ask questions to people that work in this field, share resources, education. For today's stream, you have me. I'm a licensed therapist who treats OCD, BDD, and related disorders here in Orange County, California. I've been working in the field since 2009. I also have OCD, BDD myself, so I can always answer questions from a clinical and personal perspective. But I'm so happy because it's the second Tuesday of the month, which means we have a psychiatrist with us. And that's so important because we have so many questions that are pre-submitted or asked to myself, Liz McIngvale, about medications and other interventions. And we just are not. That's not our expertise. So that's why we have the lovely Rachel Davis. So before I introduce her, just a little housekeeping reminder. We always want to let you know that these live streams are for educational purposes. It's not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can always use IOCDF's online resource directory at iocdf.org /find-help to locate a trained clinician near you. We are also not a crisis hotline, so if you are in a crisis or ever feeling suicidal or unsafe, please call 988 Suicide and Crisis Lifeline by dialing 988 or go to 988lifeline.org, your local emergency room, or 911. And then remember, we want to create a safe space, be kind and respectful to everyone, and at the end of the day, we're here to support each other. Also, this is being broadcast on multiple social media platforms and recorded, so you can watch it back on our YouTube channel or on our Facebook under Lives. Or go to iocdf.org/livestreams. So as you see, I am not alone. I am here with Rachel Davis, who, by the way, has an amazing background. Your office is beautiful. It's colorful.
Thank you.
I'm going to give you, Rachel, the official intro. So Rachel Davis, MD, is an associate professor of psychiatry with a secondary appointment in neurosurgery at the University of Colorado Anschutz School of Medicine. She is vice chair for clinical affairs in the Department of Psychiatry, medical director of the OCD program, and service director of interventional psychiatry, which includes a deep brain stimulation for OCD surgical program. Her research interests include deep brain stimulation of psychiatric disorders and living organ donation. Rachel serves as faculty for the IOCDF's Training Institute, provides consultation group supervision. When she is not at work, she spends time with her 4 rescue pups, 3 birds, and a cat. My goodness, it is like busy at your house.
It is.
What off the top of your head, what breeds are your dogs? Do you know?
Yes, a Maltipoo, miniature Schnauzer Pomeranian, a Chihuahua, and it's a Poodle Pekingese / Chihuahua mix.
Unfortunately, I had to put them down after 16 years, so I can't be too sad. But I had 2 Maltipoos, so they probably look just like my dog, your Maltipoo.
Yeah, well, and my Maltipoo actually had to put her down a few days ago, so that was sad. But she was also 16, so.
Yeah, well, I'm so sorry. I don't know if it felt like this for you. Like my dogs meant more to me than like some family members, so it was devastating.
Yes, my dogs are my family, so it is hard to lose a pet.
So I'm so sorry. I mean, it's hard because, like I said, 16 years, like, I have friends that have had dogs that have only lasted 8, 9, 10. So I always think, okay, I had 16 years, but it doesn't always make it easy. But well, welcome to the program. At Ask the Experts, like I said, we have a bunch. And when I say a bunch, I do mean a bunch, pre-submitted questions that we've had. And what we really wanted to do this year is to invite people on like you who work with medication, but also as you're talking about research and deep brain stimulation, and answer questions people have both live as well as the pre-submitted questions. But before I jump into that, what I always like to start with, just for some general conversation, One question that we always get, so I'm kind of hitting 18, questions in one, is what can people expect from, let's say, medication or any other intervention? How do they know it's working, and what would that look like in kind of real terms? If someone's really struggling with OCD and they get on a psychopharmacological program, what would that look like for relief, and what timetable does that look like?
Well, that's a good question with kind of a broad answer. So the medications that are first line or that we usually start with for OCD are the medications that act on serotonin, so the SSRIs, and those are things like fluvoxamine, which is also known as Luvox, or fluoxetine, which is also known as Prozac, or sertraline, which is also known as Zoloft, or escitalopram, Lexapro. And in depression, we usually see effects sooner than in OCD. So in depression, someone may start to feel better at 2 to 4 weeks. With OCD, sometimes it can really take up to 12 weeks to get maximum benefit. And I always warn people that you can feel worse before you feel better, and that's normal. Hopefully not a lot worse, but sometimes when you first start an SSRI, you feel a little more anxious and a little more, some people just feel kind of out of it, and that should go away within a week or two. But I do think, and this is just clinically anecdotal, but I do think people with OCD are sometimes more sensitive to side effects. I think our bodies are just kind of hyperactive, and we are more attuned to side effects and or sensitive. And so sometimes, one way around that is to go up on the doses very, very slowly. Medication is not, for most people, going to get rid of your OCD. In fact, medication doesn't even work for everybody, but what usually medication does is it kind of takes the edge off and helps behavioral therapies work better, and maybe can give you a little bit more bandwidth to engage in behavioral therapies. The other thing to know is doses of SSRIs in OCD are usually much higher than those used in depression or, say, other anxiety disorders.
A pre-submitted question that we got, and that kind of blends nicely into what you were just talking about, is we got asked this last stream: when do you decide that ERP isn't enough and medications should be added? So when you're doing an assessment with a potential client, how do we know, like, okay, hey, I think it's time that medication should be added as part of your treatment team?
I think there's not one answer, but some of it depends on what the person seeking treatment wants. And so let's say one scenario would be you have someone who's been engaged in ERP for weeks or months and just isn't able to make progress. They're not able to do the exposures. The exposures seem too hard. That they are not able to do response prevention. It just seems like there's no space between their thoughts and their actions. And sometimes medications can help make there be a little space so there can be some action. So that's one time, is when you've been doing ERP and you're just not able to fully use it. Another time would be when I meet someone for the first time and they're really struggling and say maybe not even able to leave the house, or doing things or having symptoms that are creating health problems. I might recommend that someone start with both ERP and medication to try to get at things from all angles. The other unfortunate reality, which all of you are probably familiar with, is it can be hard to access appropriate therapy. And so sometimes while someone's waiting for therapy, one thing we can do is start a medication and hopefully get them some relief, since therapy is not always easily accessible to someone.
Yeah, I'm going to ask this question next, and it can kind of be, I'm going to turn it into a broad question as well. There was a parent that asked, my 9-year-old son has OCD. I'm in Maryland. He's on Prozac, but I worry so much about sexual side effects as he gets older. I'd hate for him to miss out on one of life's pleasures. So that's a question we get a lot, is like, okay, if you start medication as a kid or maybe as an adult and you're not having any sexual side effects or any side effects, but they may one day come, or, is side effects permanent? Is it something people should worry about? Or is medication for OCD typically something that when you get off of it, people kind of bounce back?
Yeah, I mean, there are some case reports of persisting side effects. And so I don't want to say there's never persisting side effects, but that is extremely rare. Usually the case is when you stop the medication, the side effects go away. And, if her 9-year-old son decided or needed to stay on it, there are some things that can be done to treat the sexual side effects. So I think it would just be important that her son was informed so that if it was a problem, they could address it.
Yeah. And thank you, by the way. I'm just hitting you hard with these because
That's okay.
we've had so many. You're doing amazing. This is a question we get a lot too, is people, in addition to taking their SSRI, they're taking like an anxiety medicine. It could be a benzodiazepine, propranolol, etc. And this person asks, like, is it normal to require like a PM anxiety medicine long-term when taking a daily medication if symptoms are not fully alleviated? So what is that role if people are taking that anxiety medicine? Is that something long-term? Is the goal to reduce, or what's kind of the use of a like an additional medication like that?
So I will say it is normal for my patients with OCD to be on more than one medication. Unfortunately, our medications don't treat all the symptoms. And, people with OCD often also have depression and generalized anxiety disorder and insomnia and sometimes Tourette's and sometimes, bipolar disorder. And so it's normal to be on more than one medication. An anxiety medication for sleep, yes, that's very normal. I do use benzodiazepines. I'll say I don't use them first line for several reasons. One is that it's been shown that benzodiazepines can actually interfere with learning in exposure therapy. And so a tiny dose at night is probably okay. But, I usually try to avoid having someone on a regular scheduled dose or even a PRN throughout the day. One, because a PRN teaches your brain that you need a medication to address the anxiety rather than using behavioral skills. And two, just because it really does interfere with learning. But other medications at night, like a beta blocker, like propranolol, certainly completely fine and helpful. Trazodone is a common one that we use. Hydroxyzine is a common one that we use. So trazodone is an older antidepressant that we don't use anymore because it's very sedating, but we like it for sleep because it's sedating in low doses. Hydroxyzine is a really strong antihistamine, so anti-allergy medication that is sedating, and so it's a good nighttime medication. But I'd say, yes, that is pretty normal.
Okay. This is kind of a more broad question. Is there a correlation with hormones and OCD? I started birth control for early menopause, and my OCD has been a lot better. The OCD is still there, but not as loud or as normal, or as noticeable, rather.
I'd say yes, absolutely. Do we understand exactly what the association is? No. But one good example would be looking at pregnancy. So sometimes during pregnancy, people's OCD or other mental health disorders can get worse, but sometimes it can actually get better. And then it's common in the postpartum period when all your hormones are kind of plummeting for people to actually get postpartum OCD. And so we know that hormones certainly can play a role. I've had patients who've gone on birth control and their symptoms have got worse. And I've had patients who've gone on birth control and their symptoms have gotten better. So I guess the answer is yes, and we don't really understand completely how.
Yeah. Okay, thank you. We have a live question from Spence Robert at 12:04 your time, Emilio, and he says, how effective is creatine in controlling depression?
That's a very interesting question. So I will say personally, I have not tried it with a patient, but there are some small studies that do show that creatine in the range of like 4 to 5 grams a day can have antidepressant effect. I can't tell you a lot about it because I haven't tried it, but the literature is interesting, and creatine is pretty safe for most people. It shouldn't be used in people who have a history of kidney problems because it is, taken out of the body via the kidneys and can cause some problems there.
Yeah, I used to run gyms, and everybody would take creatine and have kidney stones. And
Yeah.
I'll never forget that. My doctor was like, oh, you work at the time. He's like, oh, you work at gyms? He's like, or you work in the gyms, you probably work out a lot. He's like, you have to stay away from creatine. But yeah.
Yes, it does have side effects.
There was a pre-submitted question. What are your thoughts on MDMA, or like what is kind of the latest on it? And is it something that shouldn't be used with an SSRI?
That is a fascinating question. So psychedelics are not my primary area of research, but I will say from what I've seen in the evidence and heard anecdotally that MDMA looks pretty promising. Now, I wouldn't go out there and try it outside of a clinical trial because you don't know what you're getting and it can be dangerous. should it be used with an SSRI? So the main risk of combining it with an SSRI is that you can increase your risk of what's called serotonin syndrome, where it causes autonomic dysfunction, and you can have some kidney problems and get confused. So ideally not used with an SSRI. So I guess what I can say is it's promising, but we're not there yet in terms of using it clinically, certainly.
Yeah. We asked about hormones, but there was another pre-submitted question where somebody asked, like, is there a genetic component to OCD? I'm guessing like they're saying, like, is that one of the potential reasons that people get OCD? Like, is there a genetic component?
Yes, there absolutely is. And one of the ways we know that is that people do identical twin studies. And if both identical twins have the same disorder, that's a good sign that it is hereditary. And so what's that? We call that monozygotic concordance when both identical twins have it. And in OCD, the monozygotic concordance is anywhere from 60% to like 80%. So that does mean that a good percent of OCD is heritable, but also there are clearly factors, environmental and other factors that play in, because not every single identical twin has OCD.
Thank you. I'm going to take the next question. There's a question at 12:10 that says, any suggestions for someone who's an atheist or agnostic who can't believe in God but has obsessive thoughts about possible hell and afterlife if any religion comes true? And I always tell people, like, these are the kind of, I was talking to my group last night, Dr. Davis, about like the OCD checkmate, right? Like OCD puts us in situations where we feel checkmate. So this person clearly, like, their personal belief system, they believe that they're atheist or agnostic, and OCD comes in, because I always think of OCD as like an extra, it thinks it's an extra layer of protection, but it's really just causing more like more of a disaster in your life, distrust in your life, doubt in your life, right? And so OCD is kind of peeking at you and saying, yeah, but what if God is real and you're going to go to hell and afterlife if religion comes true? And I think first and foremost, all of us have to make our own faith-based decisions. And one thing I'd say if I was your clinician is you have to make that decision based on your values. So if you are someone who's, like, let's say agnostic, right? That's something that you've chosen. We don't want to make a choice in our faith or absence of faith based on the OCD. Now, none of us on this planet can answer the second question, right? Some people believe, some people don't, some people are still up in the air, and you have to make that decision based out of values. So when OCD asks you, could there be hell? Could there be an afterlife if religion comes true? It's a question you can't answer, and that's really how you have to address this in your head. I was saying to somebody last stream is like, OCD is going to give you this monologue with a bunch of what if questions, and your job is to not make it a dialogue. The back and forth won't get you closer to an answer. So I'd say for everyone to make your life decisions based on values versus OCD. And when that doubt comes in about what if, we don't have any answers. So going back and forth in your head is just going to be mental compulsions, which is going to make you doubt more. Typically, when you abandon the question, your clarity kind of pokes through. Another medication question is pre-submitted. My son is on 2 mood stabilizers, including olanzapine. I always wonder why they don't make these medications have better names. It's always like olazapine, because he can't tolerate an SSRI due to bipolar symptoms, but his OCD is severe, including autism. Actually, I want to ask this question broad too, because I hear this a lot. So let's say somebody is bipolar, has bipolar disorder rather. I know typically they can't take an SSRI, but their OCD symptoms may be bad. How is somebody with bipolar disorder navigate taking an SSRI?
It's really complicated, but it's possible. So there's a small percentage of people with bipolar disorder that when you treat the bipolar disorder, for example, with lithium, the OCD symptoms actually go away. But that's a minority of people. So most people, you're having to treat both the OCD and the bipolar disorder. I often do end up using SSRIs, but the person asking the question, not everybody can tolerate it. So I guess first I'll talk about when someone can tolerate an SSRI. It's a balancing act. It's using enough of an SSRI that it treats the OCD symptoms, but knowing that that can cause rapid cycling. So switching from depression to mania a lot more rapidly. And so sometimes they end up on an even higher dose of a mood stabilizer, or in this case, 2 mood stabilizers, because you have to kind of balance out the SSRI. So it's not an ideal situation, but it is possible. One thing I found, and this is just kind of anecdotal, although there is some evidence, adding memantine. So memantine or memantine, depending on how you say it, is it modulates the NMDA receptor, and it modulates glutamate. And so, but in some studies, it's also been shown to have potent anti-manic activity, but it also works for OCD as an augmentation for SSRI. So I often combine an SSRI plus memantine plus a mood stabilizer, and that often allows me, 1, to use a lower dose of SSRI, and 2, to use a lower dose of mood stabilizer. Now, again, that's not going to work for everybody, but that is one strategy. But it is normal to need both, and it is normal for it to be harder to control both disorders.
This is kind of my own question based on just questions we've received past, to go kind of off of that. What about ADHD? If somebody's experiencing ADHD, can they take an SSRI and then obviously a medication for the ADHD? Does it help the OCD? Does it make it worse? Is it kind of case by case?
It's case by case. It is really interesting. I mean, you'd think that maybe giving a stimulant to someone with OCD might make it worse, but there are some small studies. My favorite one is they compared dextroamphetamine, which is a stimulant, with caffeine, and they used caffeine as the active placebo. So they were expecting it really not to work, but to have like some side effects. Well, the funny thing is, in this study, caffeine outperformed dexedrine, but both had improvement in YBOX, or improvement in OCD symptoms. So all that to say, stimulants or ADHD meds can certainly improve OCD. And I say when someone has ADHD, it's more likely that treating the ADHD will also improve the OCD symptoms. There are people, though, who do have trouble tolerating stimulants, especially if you have a lot of like physical symptoms of anxiety. So if you're really sensitive, like feeling your heart race or dry mouth or tremor, stimulants can exaggerate that or make that worse. And so for some people, that makes things more difficult. But you'd be surprised at the number of people who take a stimulant and they're like, wow, this has really helped reduce my anxiety. I never expected this.
Yeah, no, I've heard that a lot. I've had a couple people that can't. I know for me, I've never been on a stimulant, but caffeine, I mean, that was part of my OCD, was the fear of caffeine, because when my OCD was at its worst and I was just getting treatment, caffeine would set me on the edge. I mean, I had a lot of somatic symptoms, so I would feel the heartbeat, I would notice like everything, and that became an OCD fixation. I was researching everything I ate to see if there's caffeine, and obviously OCD is ridiculous because I'd be eating carrots and I'd be looking up how much caffeine is in carrots. But now you might have seen me take some sips of my matcha latte. I found right. I found for me is like once the disorder became managed, now I can handle caffeine, and I actually kind of enjoy it. But no, that's interesting about ADHD, because I'm working with someone who got on Vyvanse, and they're like, "Oh my God, this is helping me so much," because they have ADHD. But some of my other clients in the group heard that, and they're like, "Can I take Vyvanse?" I'm like, "I think you have to have ADHD first. I don't think you could just pop one in." So
yeah, I occasionally use it off label if I've tried everything else and nothing's working. I use it like as an augmenting strategy, but for one, insurance won't usually cover it off label, so that's kind of a limiting factor.
yeah. I'm gonna have both of us answer this question, but I'll have you start. So this is from Caitlin at 1212. She says, how to manage intrusive thoughts. So I'll answer it more on the clinical side, but a lot of times people ask me is like, do medication and these other kind of pharmacological interventions help with thoughts? Like, what can people experience if the medication is working in regard to like the intensity and the racing aspect of obsessions and intrusive thoughts?
Well, I'll start with what not to do. So what you don't want to do is have a PRN or an as-needed medication that you take every time you have an intrusive thought. Sometimes people use medication like that, and all that does is teach your brain that you can't handle the anxiety. But taking a scheduled medication like an SSRI, what it usually does is it won't get rid of the intrusive thoughts, but it can kind of turn down the volume, and it can also give you a little bit more space from it. So what people say is they're able to disengage from their intrusive thoughts more easily, and they can recognize them as intrusive thoughts instead of just responding to them automatically. That's the goal of medication.
Yeah, and what I would say on the clinical side, I mean, that's what we're starting to hope, is that people create some separation from the thoughts. One thing that's very difficult about OCD is that when you're activated by those thoughts, those worries, those concerns, the intrusive sensations, however OCD kind of manifests for you, it kind of puts you in that fight or flight state. It activates part of the brain that is in a heightened state of alarm, and you're sort of scanning for things and looking for things. So if I'm on a plane, for instance, and I have a thought, there's a crying baby, and I get this thought and this image of like, smothering the baby with a pillow, and I can't get that out of my head. The mistake we all with OCD make is we just ruminate on it. We just stay on it. Like, why am I having this thought? This is horrible. Go away. And because there's so much friction and we give it so much validity, the thought doesn't go away. In fact, now our brain really thinks there's a problem and it sticks in it. So it's not easy, right? The treatment may sound easy, but it's not. And I totally have empathy for people going through it. But your goal, let's use that example of on the plane, is to like, what Dr. Davis just said is like, you're going to notice that you need to separate something from it, right? Some people find it helpful to acknowledge, okay, this is OCD. I notice it because this is around my theme. I'm noticing my racing aspect, yet I'm literally just sitting in a chair. Nothing's happening, right? I'm not over the kid. I'm like 10 aisles back in my chair. My brain's sort of getting caught up in these thoughts. And our job is to change the relationship with these thoughts, not try to eradicate them. If you played thought stopping all day, you'd be exhausted and it wouldn't work. So what we're trying to do is recognize like, okay, I'm having a thought. I recognize that it's making me feel uncomfortable. I'm noticing that the image of me kind of smothering this kid is like racing in my head. I don't want to have that conflict and that back and forth. So you know what, OCD, you could be right. You may be onto something, but as of right now, I'm not going to engage. I'm not going to turn into that dialogue. And then obviously we want to behaviorally back that up. So if you start holding onto the seat arm or closing your eyes or asking reassurance, that's just going to ignite it. You want to go back to kind of doing what you were doing. But what I tell people is if this is something that's causing so much distress and makes it hard to function, definitely seeing somebody like Dr. Davis is very important, because you could work with someone to get medication, which will help as well. The next question somebody pre-submitted is, can you speak on how effective TMS is?
Yeah. So TMS, there are now several devices that have FDA approval for OCD. The first one that had FDA approval was a BrainsWay machine. It was kind of this helmet-shaped one that goes over your head. But now there's, I think, 2 other machines that have FDA approval, and they're different types of coils that aren't the helmet type. I mean, it's effective, but it's not like super effective. So I'd say TMS, I've seen it be a lot more effective for depression than for OCD. The studies show really in OCD that if someone's on an SSRI, TMS can bring down the Y box by a few points. So it can help some, but the nice thing about TMS is it's very safe. It's not invasive. It doesn't have a lot of side effects. You can be a little bit uncomfortable. It's kind of a tapping sensation while you do it. It is time intensive. It has to be done 5 days a week for at least 6 weeks. So it's safe. If you can get it covered by insurance, I'd say there's no harm in trying it. It unfortunately still isn't covered by most insurances for OCD. That said, if you also have depression, at least the BrainsWay coil is also FDA approved for depression. So you can treat your depression with the OCD coil and also treat the OCD. So that's one way that people who have both depression and OCD can get TMS for OCD.
Thank you. There's a live question at 12:18. It says, can autonomic dysfunction overlap with OCD? So I was looking up autonomic dysfunction because I haven't heard that term. Obviously, I know what the autonomic nervous system is. But I guess it's something where the autonomic nervous system doesn't function properly, usually something from a neurological disorder like Parkinson's or Lyme disease, or sometimes it says from medication. So, just having dysfunction when it comes to like blood pressure, sweating, digestion, urination.
Yeah. So, I do know that there is a higher incidence of OCD and other mental health disorders in people who have things that are associated with autonomic dysfunction. So like Ehlers-Danlos or other connective tissue disorders are associated with autonomic dysfunction. And again, I don't think we know enough to understand why, but yes, there is a higher incidence of OCD and other psychiatric diagnoses in people who also experience autonomic dysfunction.
Yeah, no, I definitely, when I was looking it up, I have access to research things from grad school, and it was saying that there is a higher rate. I think too, one thing that I always notice with people that have different health conditions, like you said, mental health or physical health, is OCD is always that cherry on the top, but like a rotten cherry. So, for instance, like I'll have clients that really do have arthritis, for instance, but the OCD fixates on it, and so they're starting to notice every movement, every feeling, every pain. So what I would look at, Stacy, if you are going through something, how is OCD making it worse? I always tell people you've got to make sure that you manage the OCD, because sometimes it takes like a real condition and makes it worse. Nathan at 1220 says, I have depression and OCD. So what I wanted to ask, the reason I wanted to bring up this comment is a lot of times what we get asked is the medication the same for depression and OCD? Can one medication kind of manage both conditions?
Yes, with certain medications. So SSRIs, like I listed earlier, can treat both OCD and depression. You will probably need a higher dose if you're also trying to target the OCD. We also use SNRIs, so things that work on serotonin and norepinephrine. Those are, they're not FDA approved for OCD, but they are effective. And those also treat depression. Things like Wellbutrin, which is just a norepinephrine dopamine reuptake inhibitor, does not usually work for OCD, although sometimes it rarely does. But that's one that probably wouldn't treat both. There are other medications like the older, we call them tricyclic antidepressants. Clomipramine does treat OCD and depression, but for example, another one called imipramine would treat depression but not OCD. So it really, the ones that act on serotonin are the ones that are going to really treat both.
Okay, awesome. I wanted to put this up there because it's a good reminder. Spence Roberts says at 1221, street MDMA can also, sometimes be fentanyl and or xylazine. The reason I want to put that up there is, I'll hear clients that are saying like, hey, I'm seeing that they're using psilocybin, et cetera. Like, I'm going to go buy mushrooms. And I'm like, please, there's a big difference between what they're doing in regulated research and kind of street stuff. So I just wanted to put that as a just general warning out there. I think people will read something and then try to kind of experiment on their own. And that's not, what you want to do.
Yeah.
So. There's a question from Matthew Bannister at 1223, a friend of the show. Hi, Matthew. Has there been any further research and successful trials with ketamine treatment in OCD? We actually got a pre-submitted one for that as well. Kind of, is ketamine working for OCD at all?
Yes. It's not FDA approved yet for OCD, but there definitely are promising studies. And I will say, so at the clinic I work in, we do Spravato, which is the FDA approved intranasal. It's S-ketamine, basically. It's one version of ketamine for depression. And I treat a lot of patients with OCD. And I'd say some of my patients with depression and OCD have had improvement in their OCD, but not all of them. I've also had patients who unfortunately have to pay out of pocket, but have gotten IV infusions of ketamine for depression, and it has improved their OCD. Carolyn Rodriguez is kind of one of the preeminent researchers who does a lot of work with ketamine and OCD. And so the data is definitely promising. And if you have treatment-resistant depression, so you've tried several medications and it hasn't worked, Spravato, which is S-ketamine, is actually a potential option for depression. And if you have OCD, there's possibility it might help your OCD as well. Just know that you won't get insurance to cover it for OCD alone.
Yeah, this is a long question that it's pre-submitted, so I don't think Emilio could put it up. But to go off of ketamine, someone said, my son has severe OCD and depression, and we did try ketamine treatment for him. He didn't finish it because it triggered his contamination. His intrusive thought is, what if this damages his brain? Despite this, I noticed he had more insight with his disease in the short period than all the years of therapy and SSRIs for him. I'd like him to try it again, but don't know how to address the contamination OCD. The reason I wanted to ask this question is when you get because I get this question all the time in my office, whether it's deep brain stimulation, ketamine, SSRIs, SNRIs, brain damage. It's always the fear. It's going to cause some permanent damage. How, if somebody comes in, how do you address that in a way that helps them recognize like, hey, this is actually going to be good for you. And, we're not just purposely trying to damage your brain.
Yeah. And you're right. That is a question that comes up often. I usually talk about how untreated anxiety and depression also causes brain damage. If you want to think about it like that, we have mice and rat studies where you show that the hippocampus actually shrinks with chronic anxiety and depression. And the hippocampus is the part of your brain that's involved in retaining memory and learning. We do know that, for example, if someone's really depressed, they can even get what's called pseudo dementia. It looks almost exactly like Alzheimer's, except it's caused by depression. And so you really have to weigh the risks, right? Is there a possibility that medication could do something to your brain that we don't yet understand or know? Sure. Probably not, maybe, but we also know that there are real effects of untreated psychiatric illness, and that does include your brain not functioning as well as it could. And so, which do you prefer? Letting your illness take a hold of your brain, or maybe taking a medication that maybe has a side effect that we don't know about, but mostly we know it helps reduce symptoms and probably improves cognitive functioning.
Yeah, what I always say on the clinical side is like, look, your what if question is based on fear. It's based on like nothing concrete, obviously. Like most of the time it's like a Reddit search or a Google search, or, well, it makes sense that it might cause brain damage or worry. Yet when you meet with, Dr. Davis or another psychiatrist and you lay it out like that, that's not just like Dr. Davis's like opinion she formulated on the way to work, right? Like this is decades of research. This is her education. Like she's coming in there to help you. And I think the OCD does not have your best interest at heart. So it's going to do anything it can to con you into thinking that things that can help you is dangerous. So I always tell people, I'm like, there's so many reasons why to move forward with what your doctor trusts. And the only reason not is because of OCD. And OCD, I always joke that if you looked at OCD's research papers, like when it comes to references, it's going to just say, trust me, bro. Like there is no research, right? So we can't believe it. Second little fun fact, when I was learning about the brain in undergrad and grad school, the reason I always remembered the hippocampus is correlated with like memory is because I was always like, oh, when hippos go to campus and study school, they're gonna remember everything, and it was just like a stupid way to remember. So I get it. The next question is from Ashton at 1222. I'll answer it first, but I'd love to get your perspective, what you see in your work. What themes do you feel are easiest to work with clinically? What themes have you struggled to work with? So what I would say is, to me, there isn't an easier or harder theme. What it is each theme comes with something unique. So obviously, if people are struggling with like harm, POCD, sexual intrusive thoughts, there's going to be a lot of shame. There's going to be a lot of guilt. Sometimes it interferes with people's moral and religious values. There's a lot of shame. They don't want to open up to friends and family. So it's not that it's harder. It's just more so that comes with some of the shame and some of the ownership and self-punishment that maybe other subtypes don't. Perfectionism is very unique in its struggle because a lot of times people identify with the outcomes. So to them, it makes sense to put in those hours upon hours rereading stuff in school or staying later at work. And there's a sense of accomplishment. And I would argue that in this country, we champion people that overwork, right? And so it's like, oh, good job, keep going. I think scrupulosity has its unique challenges because a lot of the questions or existentialism OCD, those subtypes, we're not going to get answers, right? You're not going to figure out, is this a simulation? Why am I here? Is God mad at me? So I think each of them have unique challenges. Contamination, your brain remembers everything you touched all day and it feels like it's spread and it's a lot of hours of hard work. I would say more so what makes something easier versus hard is like the openness that somebody is first and foremost willing to accept that this is a mental health condition. It has nothing to do with values or safety. They're open to doing the treatment and they really want to learn and get better. So when I have a client in front of me, if there's a certain subtype, I'm never like, darn, the subtype's going to be hard. But I'm like, if the person's like, hey, I know this is OCD, I'm ready to get to work. What do I have to do? That's when I know they're going to do well versus like, hey, I'm here because my mom is forcing me. I don't think I'm ever going to get better. The resistance. If I had to answer that question, I would say like contamination that's very minor, right? Like maybe like a 10, 11, 12 on the Y box. And it's just simple like overwashing hands and sanitizer. That's usually a little bit easier. And I would say, what's a little bit harder is when something real life is kind of connecting with the OCD. So like if somebody is having like a real health condition, and the OCD is sort of latched onto that because they're getting reinforcement from doctors. But we can pan out what is medical and what is OCD. Do you have any thoughts on that, or like when somebody comes in?
Yeah. And I'll touch on it from a clinical standpoint briefly too, just because I also do a lot of ERP. I wouldn't say easier to treat, but I will say sometimes it's maybe a little more fun to treat when someone has fears that are actually disconfirmable. So like if someone has a fear that they're going to get a stomach virus from a toilet seat, that's more straightforward to do an exposure with, because you can have them, touch the toilet seat, eat something off the toilet seat, do exposures, and then they learn 24 hours later they don't get the stomach flu, right? That most OCD obsessions aren't like that. You can't just confirm them. It's more about living with the uncertainty. But it is kind of fun when someone has a fear that you can disconfirm, and it's more simple like that. From a medication perspective, I wouldn't say there's any themes that are easier to treat. I will say there are some types of OCD that we might treat a little differently. So if someone has tick-related OCD, so let's say they have Tourette's and OCD, or even if they had tics as a child and they don't as an adult, and the antipsychotics are much more likely to be helpful at not only reducing the tics, but at also reducing the OCD symptoms. Whereas in someone with OCD without tics, antipsychotics are really kind of hit or miss whether they're going to be helpful. In someone with tic-related OCD, and sometimes even like just right OCD, where it's more about a feeling than it is about an obsession, antipsychotics can be more effective.
Thank you. I'll answer this one really quick. Somebody pre-submitted, do you have a list of psychiatrists on the IOCDF page? Absolutely. When you go to iocdf.org/find-help, one of the options is psychiatrist. I know, Dr. Rachel Davis is on there, but you can look into it. And then, there's also questions that you can ask specifically about OCD. There's a web page on the IOCDF website about questions you can ask a potential provider to ensure that they have expertise in OCD. I would say, I don't know if you feel this way, Dr. Davis, I would say like the biggest difference I see between somebody that treats OCD consistently with medications and other, interventions versus someone who's not is I'll get clients that have been on like 20 milligrams of Prozac for like 10 years. It's just usually like very low doses. And as soon as they work with somebody that understands OCD and gets in the proper dose, they start to finally feel the relief.
Yeah, either that, or I'll have people who come to me and just say they don't tolerate SSRIs. And it's like, well, no one's really worked with them to use strategies to help them tolerate it.
Yeah, well said. Another pre-submit, and then I'll get back to live. What are brain zaps? Are there other causes of this besides SSRI withdrawal? So I'll hear that sometimes, like people say, oh, I had a brain zap with the medication.
I've really only heard that in the context of medication withdrawal. I don't know if there's other causes of brain zaps. I'm not sure.
Yeah, I've only heard it when typically, honestly, it's when clients, unfortunately, which I always try to tell people not to do, go off their medication cold turkey. That's usually when I see it. So I always tell people, I'm like, please, 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 even if like you don't, just talk to a medical professional before going off of any medication. Pre-submitted, and then I promise I'll get to the lives. Could thyroid dysfunction in pregnancy or postpartum play a role in the development of OCD symptomology?
Was that thyroid disorder in pregnancy or thyroid disorder and pregnancy?
They said in pregnancy or postpartum play a role in the development of OCD.
Yes. So we know that both hypothyroidism, so underactivity of the thyroid, or hyperactivity can increase risk of various psychiatric disorders. So that is one lab I always check in people when I'm treating depression and or OCD is thyroid, and make sure that if that's off at all, we are also treating that. Again, it's kind of like the hormone question, exactly how it affects it, I don't know, but can it affect it? Absolutely.
Well said. There is a comment at 12:29 your time, Emilio, from Spence, that says, are there varieties of OCD where an SNRI is preferable to SSRIs? I've read there are cultural specific OCD related disorders where Japanese psychiatrists prescribe SNRI. So what would have the SNRI be prescribed over that?
Yeah, I wouldn't base it on at least in my experience, a certain type of OCD or variety of OCD, but I certainly do use SNRIs, and I don't usually use them first line just because they're not what has FDA approval for OCD. But if someone's tried several SSRIs and they haven't worked, I will certainly try an SNRI. Also, sometimes people have less sexual side effects on SNRI, so that's another reason to use it. SNRIs work on also norepinephrine in addition to serotonin, and so sometimes people with depression will have a better response to an SNRI than they do an SSRI. So there's lots of reasons where it might make sense to try an SSRI or an SNRI. Now, maybe there is research about themes or varieties. I'm not familiar with that, but yes, we do use SNRIs.
Thank you. Carolina, I could answer this, but you could answer it too from both a clinical medication. So Carolina asked at 1224, what is the best treatment for sensory-motor OCD? We're always going to say here, right now, the research is pretty clear that a frontline treatment for OCD is exposure with response prevention. It's a type of cognitive behavioral therapy. I always remind people ERP is a cognitive behavioral therapy because some people do a lot better if they are anxious or unwilling to do exposures, right? Which is totally understandable. We get that, to start much more on the cognitive side and work up to that. But in addition to that, those that have, myself included, I mean, we've been trained in all different modalities in addition to that. So, ACT is an example. It comes to mind at first. But when it comes to sensor motor OCD, I always think that there's 3 levels to the subtype, right? There's the initial noticing a super sense, right? Like there's let's say swallowing, right, or blinking, like let's say those kind of just like natural body actions. So what happens is the first level is you're just noticing it more because of OCD. The second level becomes the frustration or the agitation about the fact that you're paying a lot of attention. It can also come with some concerns like, if I don't blink right, my eyes will become dry. It will affect my eyesight. Sometimes there isn't like a fear. It's more so just the discomfort of being hyper fixated on it. And then there's the third level, which now that I'm hyper focused on it and I'm agitated and uncomfortable, now I can't be, good at work, or I'm going to be distracted during my game, or I'm not going to drive well. So you kind of have these 3 layers, right? And so we're not going to work on the first layer out the gate because that's what your OCD is doing to you. And that's where, we can't just tell OCD to stop, but we can work on all the what if questions. What if I can't drive properly? What if because I'm not blinking right, my eyes are going to get dry and I'm going to lose my eyesight, right? Those are what if questions with OCD, and we tolerate that doubt. We say, okay, those things may or may not occur, but they're not occurring now, so I'm not going to engage, right? The second level is we can manage our frustration. I'll have clients sitting in my office and they're like, oh, I'm noticing my breathing. And I'm like, okay, let's both notice our breathing. Hey, let's do a deep breathing exercise where all we do is notice it. What's happening? We're in an air conditioning office. Nobody's dying, right? Like paying attention to on purpose and taking away that shock value. And then you're just left with the first layer. But after there's no reinforcement, that starts to become boring.
Yeah, and what I've seen is sometimes something might be labeled sensory motor OCD and can actually turn out to be a tic disorder or Tourette's. And the overlap is that they both involve focusing on a body sensation, but with Tourette's, it's more like, we call it premonitory sensation, where you feel an urge, like you have to move a certain body part because you just feel the sensation and it feels uncomfortable. So sometimes that's distinct, but sometimes there is definitely an overlap where someone has a tic-like component and a sensory motor component, and in those cases, that's also where I might prescribe an antipsychotic in addition to an SSRI. If someone's done ERP for years and it's not working for sensory motor OCD, I kind of wonder, well, are we missing like a tic component of this?
Well said. I always tell people, make sure you're getting a good assessment. Phyllis asked at 1237, do SSRI dosages need to be adjusted in older patients?
Sometimes yes. So sometimes older patients have kidney disease or liver dysfunction that would require lower doses. Also, sometimes older patients are more sensitive to medications. So one thing is, if I'm starting a medication in someone who's older, I will probably go up a lot more slowly. They may still need the same maximum dose, but their sensitivity may be different. And if they have any kidney dysfunction, we will then need lower doses.
Emilio, if you could put up a grandmother's garden comment at 12:40. This was response to, there was an earlier question at 12:38 from Kay that says, how should I do exposure response prevention for false memory OCD? But I think this is a great answer to your question, Kay, from a fellow, OCD community member. Maybe it happened, maybe it didn't, whatever. Don't confirm there's any possible threat with tension. Be nonchalant. Remember, when we get worked up, so in false memory OCD, something happened 8, 10, 15 years ago. You remember it. You're not sure if it happened. You're trying to figure it out, right? All of that investigating, that fixation, that kind of time travel to the past, that conflict is going to keep you stuck, and it's going to keep that being relevant. And what Grandmother's Garden is saying is your response is, hey, maybe it happened, it didn't, whatever, right? You're not getting tension. You're being nonchalant. You're treating the what if question as a what if question versus I have to validate if this thing occurred. So I know it's hard, Kay, hang in there. But the more you're trying to get those answers, I always say it's like making a photocopy of a photocopy of a photocopy. It's going to get more blurry and be harder to even remember what's true from false. There's a question at 12:38 from Mohammed that says, how much time to treat sexual orientation OCD? What is like a good, I mean, obviously that answer is hard because there's so many other factors, but generically, like how long should somebody, whether it's with ERP and other interventions and maybe medication, should people at least start to see some relief and start to see some shifts?
That really depends on the person, but with medication, we say give it at least a good 12 weeks at the maximum dose. And so unfortunately, it can take a long time.
Yeah. Thank you. Yeah, I would say, I mean, I think the biggest thing is a lot of it is like willingness, how active someone is. And a lot of times a client needs medication, a higher level of care. So all that comes into factor.
And I often try to reassure people that just because you're not getting better doesn't mean you won't. So just stick it out with me. Like that's one of the biggest things you can do is just stick it out and keep moving forward.
Well said. Connect for OCD asked, if somebody has treatment resistant OCD, how can a person try target ultrasound treatment?
So there's something called low intensity focused ultrasound, which is super promising and I'm very excited about, but it's only available in the research setting. So you'd really have to find a clinical trial. I don't think there's anywhere that's offering it clinically. But if you go to clinicaltrials.gov and you could type in low intensity focused ultrasound and OCD, you could see if there are any clinical trials near you that you could participate in. But it's super promising. It's a non-invasive type of treatment that, I mean, some of the early results are almost too good to believe, but it's very interesting.
Afsana at 12:47, if you could put up her comment. Afsana, we actually answered your question earlier in the live stream. So this was the question I asked you about somebody who has OCD and bipolar and isn't able to tolerate the SSRIs. They're on olazapine, but it's not helping for OCD. So what I want you to do, Afsana, is you had asked that question last week and it was so I used it for this week. After this live stream, if you go to the IOCDF's Facebook page and you click under videos, this will be uploaded right away. Or if you go to youtube.com/IOCDF, this will be right away. And I did ask this question, you'll see it on, and Dr. Davis that's why I'm not scared to answer it again. She gave a very thorough and precise. So please, please, please watch it back. I promise you I asked her question. She answered it really well. If you have any trouble finding it, either the live stream or where we ask the question, you can always email info@iocdf.org, or next week ask and I'll walk you through it, but we definitely answered it. Wendy at 12:50 asked, what type of therapy and medication do you recommend for the just right type of OCD? They have a lot of anxiety going on.
Pretty similar to what you would do for any other type of OCD. So exposure therapy. If I think I mentioned earlier, if there is like a touretic component where it feels like they have a premonitory sensation and they have to move, and it feels like there might be some tic component, that's where I would also add an antipsychotic. But otherwise, I would say ERP and SSRIs would be first line.
Yeah, and one thing I always tell people, Wendy, is what Dr. Davis had said earlier. The just right OCD doesn't always have like a doom and gloom outcome. Sometimes it's just like, I need to get this feeling, and if I don't get this feeling, I can't move on. So I had that subtype. It was annoying because there was a lot less noise in my head. It was more of a feeling or a sensation. But what I found is doing just wrong really helped me. I was like, look, I'm going to be in control. I'm going to do things just wrong, and I'm going to get a sharp discomfort, but it will fade, versus this slow crawl that happened until I gave in. I even had it with some symmetry. So sitting down, if both of my shoulder blades didn't hit the back of the chair equally and just right, I was doing this for like 20 minutes. So I finally just was like, I want to sit wrong and move on. So hang in there, Wendy. Katie, I see that your question was answered. So Emilio put how to access psychiatrists on the IOCDF website. Make sure you're clicking kind of on the toggle down options. It's definitely there. I know we're almost out of time, but Rachel, Nathan asked at 12:54, what about troriluzole? Just rolls off your tongue. I don't know.
Riluzole, is that what? I don't know. What time was the question asked?
It was at 12:54, or it's up on the screen if you look on the screen.
Oh, okay. I don't know. That's maybe something I haven't heard of. Let me just look it up really quick.
Yeah, why Rachel is answering that. I'll just say, Lana, I love your message about, everyone struggling with a family member with OCD, somebody close. What I liked about what you said is dismantling the main lie that originated OCD. I think that helped me as well when my therapist would ask me, like, how did you even come to this conclusion, Chris? And when we kind of backed it up, a lot of times it was a combination of like things I heard, a gut feeling, and stuff I found online. And my therapist would say, do you do that in other areas of your life, or do you recommend people do that all the time? And I was like, no, that's not how we come to conclusions. That's not scientific. So sometimes knowing that I created that obsession on a bed of lies really, really helped.
So I did look it up. Troriluzole is undergoing phase 3 clinical trial. So that means in humans as an investigational treatment for OCD. And we do use riluzole, which is a glutamate modulator. So this looks like a pro-drug version of that.
Awesome. All right. Final question. This was from last week. So I wanted to get all the questions from last week that people submitted because they knew you were coming. Someone says, hi from South Africa. Any tips or information about SSRIs for OCD? I'm going to a psychiatrist in the coming days as normal therapy and treatment alone is too difficult. So what would be just some final recommendations? That's why I saved this question for last. Somebody's about to go and see a psychiatrist for an SSRI because they've been struggling alone. Like what to expect in that first session, or what can they bring to the first session, question wise, to get the most out of that first session?
Well, I think there are maybe 3 things that you should know that you can help make sure your psychiatrist doesn't give up on you or not get you to appropriate doses. So one is, don't give up on the SSRI just because you have side effects. Be creative about how to tolerate it. Sometimes I go up by 1 milligram a week. 2, you need to go to higher doses than sometimes than what's FDA approved. And so, encourage the psychiatrist to research that. You don't have time for me to tell you specific doses for each drug, but you will probably need higher doses. And 3, don't give up. So get to a high dose and stay at it for at least 12 weeks. And then you may need other augmenting strategies. Maybe an SSRI alone is not going to be enough.
Amazing. All right. Well, I want to thank you so much for coming on the live stream. I don't know if you could see it, but in the comments, so many people have been saying nice things. So as always, I want to thank I always consider y'all our second guest, everybody in the chat watching live, asking questions, submitting the questions in previous lives that we asked, the pre-submitted questions. I have to say, Rachel, I love that you got through so many questions, but I was noticing, I'm like, it's not even that she's getting through them quick because she's giving one-word answers. She's like very concise, and I love that because like we had so many questions, and every week when I'm pulling the medication questions for the psychiatrist, I get heart palpitations because I'm like, it's going to take 7 years, but you got to good ones. We'll definitely have you back. So excited to have you here, Dr. Davis. Thank you for your expertise. Thank you everybody who joined, asked questions, and engaged in the chat. We'll definitely have Dr. Davis back. Amazing, and she does amazing work work, and she's great friend of the foundation. If you enjoyed this live stream, or like I said, if you asked a question but you came late and we might have answered your question, just go to YouTube or go to iocdf.org/live streams for upcoming live streams. We're here every Wednesday at noon Eastern, but also make sure to go to youtube.com/IOCDF, or if you go to facebook.com/IOCDF. If you go up, I think it's either videos or live, the tab, you can watch this back, send it to someone that might find it helpful. Thanks again to Dr. Davis. Go to iocdf.org for all of your OCD needs, and we'll see you back next week for live stream programming. Thank you so much. And remember, OCD is a liar, kick its butt, and get better. Take care, everyone.
Thank you.
Bye. Thank you.